sometimes the perimenopause transition, you're getting periods more frequently and much heavier than you had before. And it's super frustrating, right?
But we don't need to suffer through that.
You don't have to suffer through it. There's many options.
This is MomCast, powered by the Local Moms Network. Moms, picture this fun scenario with me. Your daughter is going through puberty and you're going through perimenopause. Well, that's the fun situation going on in my house these days. But whatever stage you're at, hormones are the key running everything. Maybe you're postpartum. At any stage, though, we want to feel supported. And here to have that conversation with us today are our gynecologic experts, Dr. Karlie Provost Goldstein and Dr. Leigh Rosen of Essie Care, a boutique practice on both coasts in LA and here in Manhattan and Fairfield County, Connecticut. Thanks so much for coming back.
Yeah, thanks for having us.
Thank you.
There's a lot going on as women. We're navigating a lot of hormones. What are the two ends or extremes that you see in your practice?
So we see everything from, I do see some teens for my endometriosis practice, and we talk about, what's normal and what's not. And I actually do some teen education visits where we just spend a lot of time talking about what to expect and what's normal, what's not normal, what are some strategies that can be done when you're a teen and going through all of this. And so I do little visits like that with, their mom can be present or a family member, or they can come in by themselves with mom's permission or adult's permission. And we can talk about sort of all different span without having to perform any kind of pelvic exam or speculum exam on
just talking.
Yeah. What's happening with the menstrual cycle, what to expect when it happens, what to expect when, basically all different spans of it and what you should look out for,
I love starting there because how awesome would it be as a teenager who's going through all of these shifts in their body and already feeling self-conscious to know this is my go-to person. Mm-hmm. And I can start that relationship with a doctor early on so I feel comfortable saying, hey, I have a problem.
Mm-hmm. Absolutely.
I wonder, what is it like when someone first comes in and you have on the early end these types of conversations? You said no exam. What are the things you're discussing?
And I like to tell them that up front so they don't have to feel that pressure. But
Right.
And it's funny, I do see a lot of I always laugh. It's like I see a lot of teen angst, I see and it takes me a long time to break the
pap
ice.
smears sound scary.
Yeah. And
We don't like them as
I tell them
adult
there's
women. Come on.
there doesn't have to be a physical exam at all. We can just talk, but I get a lot of some cold shoulders and looks for a good 20, 30 minutes. And then every now and then a smile will crack and I'll be like, yes, I'm in, but it's it's very funny.
You
And
have to get them to trust you.
yeah. And it's and they're, but I get that whole, there's definitely a teen vibe that's
A wall up,
a
we'll
wall,
call it.
a big wall. Yeah. That I work really hard to get past. And sometimes it doesn't happen. I don't get past it, but the mom appreciates the visit and whatever, and it's fine. And maybe they do appreciate it, but it's it's funny. I like it. It's it's a very characteristic time.
I want to call it a luxury to have that, but I feel like it should just be the norm.
Yeah. But I know that, it's probably not happening on that pediatrician visit that's 5-10 minutes and the insurance visit that's are you getting these shots? Are you getting these exams? You want your flu shot? You're the right weight? Okay, let's go. And then that's it, and that's a very sort of quick visit that they're limited by with how many patients they have to see in a day, and so often that's not the time where you get to really get all of these questions in or hear about, what are periods and are they normal or not, and if you should be missing sports or school. I always talk to teens about that. A period shouldn't stop you from competing in a competitive sport or from going to school. It shouldn't be so painful and debilitating that you have to stay home for 1 or 2 days every cycle, every time you get a period, that you need to miss school and miss an exam or have an emergency room visit. That's not normal, right?
So would you say it's normal to need a couple of Advil and a heating pad? What's sort of the realm of what you deem appropriate?
A heating pad, a couple of Advil, maybe 1 to 2 Advil, and then on day 1 of their period and that they're crampy. And so 1 to 2 Advil may solve it. But if they're really having to if mom's giving them 3 or 4 Advil multiple times a day and several days a cycle to get through their period, then that's not normal, if it's like one day of kind of crampiness, they can get through it. It doesn't really stop them in their tracks. They take an Advil, they put a little heat on, they go to school, they're fine. But if they're having to call out misrepetitively, absences are becoming a problem with school, that's outside of the realm of normal,
I know you're an endometriosis specialist.
Mm-hmm.
When does that kick in? I mean, at what age would you say it becomes something that you explore?
Great question. So I actually see patients all the time that from their very first period, things were abnormal or things were off the span of normal. And their first period was debilitating and a big event or an ER visit or something happening. And so I see patients like that. I also see patients with endometriosis that maybe the periods themselves are not that bad, but they've been on a long goose chase about bowel symptoms and told they have irritable bowel disease or irritable bowel syndrome, or they have chronic diarrhea and constipation and upset stomach. Like I see a lot of teens with nausea and college kids that have debilitating nausea and bloating, and they can't figure out what's going on.
And endometriosis is the reason?
It could be, yeah. And many times those patients are seeing GI doctors, and they're not finding me right away. So I would say bowel symptoms that are really correlated with their cycle, their hormone-sensitive bowel symptoms are more commonly endometriosis, So meaning they happen certain times of the month. It's very predictable. Like with the period, they have diarrhea. Then 2 weeks later, they get constipated. And then they're very bloated and on sharp pain around 2 weeks after the period. And then leading up to the next period, then they start getting the loose stool again. They get stabbing.
So it might be a good idea to sort of keep track, right, of symptoms?
Yeah, it's a good idea. And that can be a first lesson in sort of like, feeling empowered, like they're doing something and tracking something to do that. I heard some teens mention lightning butt pain. They tell me that. And they're like, oh, yeah, they're like the sisters have, like all of them in the family have, yeah, that's one of them that they were talking about. But yeah, I think tracking these things, they don't have to go crazy with it, but just kind of knowing like, oh yeah, I keep having to miss the track meet because I'm bleeding through my clothes and, or I'm bleeding through bed sheets or I'm going that, these things are not normal, right? Changing a tampon, a Super Plus tampon, a Super Plus overnight pad every 30 minutes. First of all, it's really frustrating having to run the bathroom all the time and have all these pads and tampons. But in addition, like that amount of bleeding, especially if it's not happening, if it's something new for you, is not normal, on any span of life, not just for teens, but even middle life, perimenopause, all those times, it's
Dr. Rosen, you see a lot of this abnormal.
I do see a lot of abnormal bleeding, and I'll get to that. But I think, as I've been thinking about what you said at the start of this, being a teen and having all of these things happening to your body, I mean, it's brutal. And I think that it can feel just so scary and overwhelming. And even if you're super close with your family and you feel like you have open dialogue, I think it's so important at that age to have, a provider who you feel like you can talk to, who's not going to you don't have to worry about being judged or anything at all. And so like you were talking about having these meetings, you'll have like a visit, and it's not an exam. It's nothing scary. It's literally just talking and kind of getting to know each other essentially is so important because I think about it's made me think a lot about how much of a big deal that is.
It is. And I'm wondering, obviously this isn't a, masterclass question, but how should we tell our girls to prepare for their first period? I remember putting together a little period kit for my daughter just to keep inside her backpack.
Well, that's awesome. Yeah, I think that's really awesome.
Should we be doing that?
Yeah, we should be doing that because it takes the fear factor out of it and that they don't have to like go ask someone. And, they're trying to improve access for periods in schools and have pads and tampons for free in the locker room and the bathrooms and stuff like that. But that's not across the board everywhere. And Lord knows in New York City, it's very hard to find a clean bathroom anyway, much less like the right appropriate supplies there, right? And so I think having that in their bag and just like, we don't know when this is going to happen, but let's just have this little pouch in there and have it be something cute or something they like or their favorite color or whatever. And it can be more inconspicuous and that they can hide easily if they feel self-conscious about it. But I think that's really great to have that in there and, that they don't really have to fret, don't have to ask someone, don't have to tell someone right away if they don't feel like it that day,
I think the generational changes that we're trying to make as moms do encompass, taking the stigma out of things like getting your period.
Yeah.
Because I think it was scary for me a generation ago.
Yeah.
And I'm celebrating that this is going to happen one day soon with my daughter. And I'm trying to uplift it because, let's be honest, as moms, we know being a woman is hard. A lot of hormones, a lot of changes. Dr. Rosen, tell me about, the other end of the spectrum, perimenopause, menopause, postmenopausal care.
Yeah.
What are you seeing and treating in the practice?
So I am seeing a lot of patients who are suffering from abnormal bleeding. So maybe for most of their life, they had pretty regular periods that came every month for, a couple of days. It was fine. It didn't inconvenience them. And then suddenly something started to shift. They became much heavier, longer, unpredictable. And so part of the workup for that is usually an exam and also imaging. And maybe on imaging, they will find a structural cause of these changes. Sometimes it can be hormonal for sure, but often it's like I find hormonal maybe also with a structural issue, and the combination just exacerbates everything. So things like fibroids, polyps, these are growths that can form on or within the uterus that can cause.
And how do we find those? What are the tests that can actually locate something like that?
Usually a pelvic ultrasound or a pelvic sonogram, as well as an MRI. These are the most common imaging that's used to identify these types of things. And so that's often what I will see. So sometimes it's a structural issue that needs to be or can be fixed or treated. There's various treatments, medications, procedures by radiologists. There's also surgery to fix these things.
And when we say something like polyps, I know our minds can sometimes go to the worst case scenario.
Yeah.
Are some of these cancerous? Are most of them benign?
Right.
What's sort of the range that you see and treat?
Most of them are benign, but it can certainly be cancerous. So often like a polyp, if a polyp is found in somebody who's having bleeding issues, we will recommend removing that, not only to help with symptoms, but also to send it for pathology so they can, definitively rule in or rule out cancer. And, there's certain, I guess there's certain factors that would make you more worried. So for example, if somebody has gone through menopause and they're not bleeding anymore, and then suddenly out of the blue, they start bleeding, that is always a problem. So for anyone listening, if you have gone through menopause, meaning you have not had a period and you don't get a period anymore, and then suddenly you start
more than
bleeding.
A year.
And I'm not talking about a period. I'm talking about a spot of blood that is abnormal. Got to get that checked out. And so that anyway, so something.
And it sounds scary, but I'm just so happy to hear it.
Yeah.
So we need to know what the red flags are so that we don't let them linger, because so many times we're suffering in silence.
Totally.
Correct.
I've met many patients who've said to me, oh yeah, I went through menopause 5 years ago, but I started getting my period again last year. And I say,
no,
oh no.
That's not normal.
No, and I'm worried, and now we need to do a biopsy. We need to check things out. So there are certain, situations that are more concerning for a potential, cancer or something like that when it comes to bleeding.
And just to stick with that sort of investigative surgery that you do, I know that a lot of women who have C-sections will have their fallopian tubes removed if they know they're done having children. And I've heard so much about the fact that actually the fallopian tubes are where ovarian cancer typically begins. So you're sort of removing that source. Is that true? And what are we learning about that?
Yeah. So the fallopian tubes, they can reduce your rate of ovarian cancer by removing them. And we do think that a lot of cases of ovarian cancer are what we call a primary peritoneal disease that maybe starts in the tube first. So that is a risk reduction strategy that can also help to prevent a pregnancy. And so it's kind of like what we call for as a 2-for-1 in gynecology is like it's recommended if you are looking for a way for birth control, you don't want to be on hormonal birth control, and then we want to do something risk reductive at the same time, then that's a great strategy. And it can be done at the time of a C-section. It can be done with a minimally invasive, like a quick laparoscopy procedure that takes Dr. Rosen or I like 15, 20 minutes to do a case like that. And it's not that big of a downtime to do a risk reduction procedure like that with the tubes. There are other ways to reduce risk and to monitor. And I think it's really important what Dr. Rosen was saying, that postmenopausal bleeding is always abnormal. When you go through menopause, it's defined as not having a period for 1 year. And so anytime that you don't have the period for 1 year and you've gone through menopause, any bleeding like she's describing after that is abnormal. And you may have some spots of blood, and it doesn't mean that it's necessarily cancer, but you have an exam and maybe there's something bleeding from the vagina because the vagina is dry and lacking estrogen. And there's something we can do to help that. And it's not coming from the uterus. And so not everything is like, has to be doomsday, but it's certainly worth investigating. And doing that initial ultrasound can help determine if the uterine lining is thickened, if it looks like a polyp, if it just looks like the lining is thickened and that's suspicious for hyperplasia, and then a biopsy would be warranted. And so Dr. Rosen and I both do, direct guided biopsies. So we don't do a lot of endometrial biopsies in the office. They can be quite painful and, we do when necessary, but we can actually do, like Dr. Rosen does all the time, these quick cameras where she surveys inside the uterine cavity and she sees if there's anything funny looking, anything abnormal. And even if there isn't, then she'll do direct biopsies while looking at what's there and directly biopsy anything abnormal. And that's one of the best ways to biopsy inside the uterine cavity, rather than doing like a little straw biopsy in the office that is random and only a small amount of tissue present because the patient is awake and it's uncomfortable. I have patients that sometimes come to me that have had that and that was normal, but it didn't paint the whole picture because it was a quick, limited biopsy in the office. And so I would say, if things are continuing to happen and you're still not certain, then it's always good to sort of investigate it a little deeper. And that's what we do, And I think there's a lot of options for patients surrounding perimenopause and menopause that they're not really told are options, right? I have a lot of patients in their 40s that are not given the option for risk reductive surgery. They're not given the option that they don't have to be on birth control forever if they don't like their period, right? There are options if the uterus has heavy bleeding and has fibroids or has endometriosis or adenomyosis in the walls of the uterus. They don't have to suffer forever and wait for menopause. I think a lot of times women and moms are told just wait for menopause. Some patients will by choice. Yeah. And it's both reduction of their symptoms and reduction of risk for them. And it's life-changing, and I always think it's their choice on when they're done having kids and when they're done using their uterus for periods. The uterus is actually designed. It's not designed to have periods all the time. The uterus is designed to have a baby and to produce and hold a baby and then to deliver. You're having periods and ovulation every month to try to get pregnant again. The ovulation happens every month. You build a cyst, you ovulate that cyst, you release the cyst collapses. Every single month, everyone gets an ovulation cyst that's ovulating and having periods, right? Then the ovulation cyst collapses, you get a period 2 weeks later, and that is shedding of the lining. When the uterus doesn't see a pregnancy, the lining sheds, right? And so that process happens your whole reproductive life cycle until you go into menopause. You're producing a cyst every month. You're shedding the lining unless you have PCOS and you have 6 months in between or abnormally long breaks between the periods.
Again, hard to be a woman.
Right? And then in perimenopause, there's a lot of confusion around, are the periods just going to go away, quietly into the wind and just like cease happening and they go away for 6 months and then not happen for a year and then it's gone? That doesn't always happen. It's not always so pleasant of an experience like that. Sometimes patients in perimenopause will get periods every 2 or 3 weeks as the ovaries are pre-selecting a follicle,
pumping out the last
of the hormones. They're ovulating erratically, and then the periods will come more frequently. And so you're like, hey, wait, I thought this was supposed to just like disappear quietly into the wind, like 6 to 8 months break, and then a year break, and then it's going to just nicely go away. And that doesn't always happen. Sometimes the perimenopause transition, you're getting periods more frequently and much heavier than you had before. And it's super frustrating, right?
But we don't need to suffer through that.
You don't have to suffer through it. There's many options. And we have friends
and it's not
that
just surgery. I mean, there's a lot. There's a lot of
What are
options.
some of the other options, Dr. Rosen, that are at our disposal?
One of the options that works really well is something called an IUD, a progesterone emitting IUD. For example, like a commonly known one is a Mirena, for example. And this is it basically emits progesterone into the uterus, and it really helps with not only bleeding, but also with pain, especially when you're in perimenopause and I love how it's being talked about so much more. And people are advocating for themselves and they're seeking specialists who provide, care for this specific area and have a lot of knowledge about it. And you might be starting some medication, some hormones. And so as you do that, then you start to have more bleeding from the uterus. And so you got to kind of come at that as well. And so a Mirena IUD is just one example of something that is not surgical that can really help with abnormal bleeding, heavy bleeding, and pain as well. And that can be something that can be placed in an office setting, or we offer it with anesthesia in the surgery center because it's kind of painful to get it placed, quite painful. And so
Thank you for the honesty.
Yeah.
I always like anyone who's coming to me who is thinking about an IUD, I always say, okay, we have options. These are how we can do it. We can either do it with some.
Yeah, make yourself comfortable if you
100%.
can.
Why are we doing?
not?
I mean, it's crazy.
Yeah.
I don't
And
understand.
I love what you said, because when I turned 40, I did not know the word perimenopause.
Yeah.
And 6 years later, I cannot move 10 feet without
Talking
Yeah.
about
either talking about
or hearing about
perimenopause,
it. Yeah.
commiserating about symptoms. But I
Yeah.
think all this education is so important.
Yeah.
Hormone replacement therapy had a bad rap. Now it seems very popular again. Let's take out all of the trends and purely discuss science. What are you seeing in the positive benefits that women get from HRT?
So first of all, there's a lot of debunking of myths that's been happening this last year or two, which is very exciting. And we now know, and we've known for many years, but the studies that were done, first of all, that were like the Women's Health Initiative, the WHI study that everyone talked about for years and used for fear-mongering of patients, was done with very high doses of equine horse hormone. The study involved patients that were 65 and older, and they had never been on hormone therapy, and they didn't start it until they were 65. And so they'd already been in menopause for 15 years.
Wow.
And then they already had heart disease and risk factors. And then they started on high-dose horse hormones. So first of all, that's the background of that study. And we've seen a lot of very exciting changes in the menopause and perimenopause and hormone world that these studies are being debunked, that we now know that in very low dosing, bioidentical hormone replacement, meaning the same type of hormone that your body produces, not horse hormone, but your own body produces, is very safe and very effective. And in most patients, well tolerated and safe. Even in cancer patients that have had ovarian or breast cancer may, most of them, be eligible for a vaginal estrogen cream that can help vaginal mucosa with things like recurrent UTIs, recurrent bladder infections, dryness, painful intercourse. And those are options even for those patients. And then there are a lot of options for hot flashes and hormone symptoms that are non-hormonal even now that we have. And so that's very exciting too.
Yes, I just heard
all
in the
different-
news
there's
about
just a new
another
one,
one.
another new one that helps with hot flashes. And so that's very exciting that there's more talk about it, there's more research, and there's a lot more options for patients. And even patients that want something vaginal that's non-hormonal, there's hyaluronic acid for the vagina, like we put on our face, and that can help with vaginal moisture and it's non-hormonal. So I think there are so many real options for patients now, which is exciting.
So you don't need to take a pill or wear a patch.
You don't necessarily have to. And there are options. There's transdermal formulations. There's really, and we know that transdermal, meaning on the skin, so whether it's a patch or a cream, those formulations are quite safe and they're not absorbed orally through the liver and the stomach, and the risk of complications and side effects from those are much lower. And so the exciting news is that there are many options in hormone therapy now that we didn't always have, right? And it's quite exciting to see that they're very safe and efficacious dosing at very low doses, and you can feel a lot better. It's life-changing for patients, you know.
I also think it's interesting to read and hear more about the hormone replacement doing something about things like cholesterol and high blood pressure, not connected to the symptoms of perimenopause, but maybe they are connected because our body works, it's all connected. So maybe we're getting benefits that we don't even imagine would have been there.
Yeah. And when we think about it, we know that heart disease is one of the biggest killers in women. And heart disease starts to become, much more prominent at around age 50, 51, when women go through the menopausal transition. And that's when we actually see lipid panels changing and high cholesterol happening. And maybe their blood pressure just started to go up and they were always a low blood pressure person before. Right. And then midsection weight gain, which is the dangerous sort of visceral weight gain that we worry about, rather than if you were your whole life gaining weight on your thighs and your bottom that's pear-shaped, it's not as dangerous as growing visceral fat, which is midsection weight, puts more danger for your heart and for your surrounding organs on your body. So there's a lot of conversations happening now around that. And we do think that, when we're changing the talk and when we're changing with hormone replacement, hopefully we're not just necessarily evading those things, but maybe we're changing that timeline of when all of these conditions sort of start to happen at 50. A long time ago, right, we weren't living until 90 or 100. Now we're living till 90 or 100, but we're still going through menopause at the same age of 50, 51. And so
our quality of life needs to stretch so much further.
Correct. Mm-hmm. And so it's different. We're having a lot more conversations now around longevity and how you can not just live till 90 or 100, but actually feel good until those years, right? And stand up and do squats and get up off the floor without using your hands and lift weights and have good bone density and not have a debilitating, frail end of your life at 80s, 90s, where you just don't feel good and you're depressed and you can't walk and you can't use any muscles and you're, no one, it's miserable to see people suffer like that. And, see my own grandmother like be weak and really frustrated because she used to dance twice a week and walk a mile a day. And no one wants to go through some of
our energy for learning and changing our habits comes from, because I think we can look at the older generations in our family, mothers, grandmothers, and say, God, I don't want to be like that. I do want more vitality, but I'm also willing to do something about it.
Right, exactly. And I think as we have kids later, right, for our grandmothers that have kids at 20 or 21, and they're still living till 90, they went through all of those things at a much earlier age, right? And so when someone tells me like, oh, why are you lifting weights so much, or you're being crazy, or you're really working hard at that? And I'm like, yeah, but I had kids at like 34 and 39, and I want to be a young, healthy, fit mom until I'm like 90. And when I'm a grandma, I want to travel the world and go to Italy and go to Bora Bora and do all these things. I'm 46 with a 7-year-old.
I need to be
exactly
alert and alive and healthy for him.
Yeah, and I take it as my responsibility for being an older mom that I am going to work 10 times harder to be super fit and healthy so that I'm around for my girls, like all throughout their life. And I want to be with my grandkids and I want to travel the world and I don't want to be struggling.
Motivation.
And, it's a huge motivation. And so that gets me doing it every day,
Well, yes, you've inspired us. Dr. Rosen, I imagine that just like young girls have sort of a wall up about being honest about their bodies and feeling a little self-conscious, I'm sure there are women in their 40s and 50s who don't want to say, I have vaginal dryness, sex hurts me. I mean, you have to sort of get a trusted relationship with them and pry information from them as well.
Yeah, I mean, and I think that's the whole point of really trying to get to know my patient, just sit down and say, so like, are you having vaginal dryness? Are you having this, right? I'm like, tell me about yourself. Where, what do you do when you're not here in the office? Are you currently working? Tell me about your family. Where'd you grow up? I really like to get to know my patients and just get a sense of who they are, what gives them stress, what doesn't. And then you kind of go from there. And then I find that it actually is quite easy to have open communication and dialogue.
The stress is an interesting one. I feel like when a doctor says to me, are you stressed? I think, yeah, I'm a mom.
I don't
of
ask
course
that
I'm
question.
stressed.
Who asked that question?
But it's so funny. Sometimes stress, it just becomes our baseline.
Yeah.
So we don't even know that stress is what we're feeling because we're so chronically stressed. Right. So the conversation means the world when you're talking to a doctor.
First of all, I don't ask anybody if they're stressed because if you say that you're not stressed, then I'm like, I don't believe you.
You're right.
But also, one of the things that's so important to me, when people come to me and they're telling me they have heavy periods or they have this or they're having infertility and they're like, but I've been really stressed and like, I get upset actually, because I'm like, it makes me feel like they think that part of what they're going through is because they're stressed and they're not managing their stress well. And I always make a point to say, no. That is, your stress is not why you exactly.
Yeah. And I think, unfortunately, people are told that. And we hear that a lot. They blame the stress on
your stress
infertility
is not,
or endometriosis or whatever.
correct.
And that's not true.
Wow.
Your stress is not why you have fibroids. Your stress is not why you have Asherman's. Like, this is no. And I really make it a point of always, like, because I notice it'll slip in so frequently. Be like, oh, well, I went through a tough time at work and I really wasn't exercising, or listen.
This is life.
Exercise is great. Eating healthy, all these things are great. But you didn't, almost all of these conditions, they don't come because you didn't go to the gym last week,
Yeah.
And so I think that's so important to...
I love this education, and I know you do a lot more of it on Instagram. Tell us where to find you.
So I am on Instagram, Patient Surgeon Mama.
I'm Leigh Rosen, MD.
And then we have our website, esse.care. So we have a lot of information on there too.
You two are such a breath of fresh air. I love all of the things that I learn when I'm with you, but most of all, this calm that I feel, because it can feel frantic sometimes talking about our health. Thank you so much.
You're so welcome.
Thank you.
Have a great
Thank you
day.
for
Thanks so
having
much for
us.
having us.
Moms, we're so grateful you're part of our community. Don't forget to rate and review MomCast to help us spread the word, and follow us on Instagram at the Local Moms Network. I'm Dimitra Ganyas. We'll find you back here next week from Stanford Studios.